I'm very excited to present you the first results from our SARS-CoV-2 seroprevalence and mortality survey in Omduran in Sudan. Is my presentation up? Not yet. Well, I think the slides are missing. Yes, now they're here. Super.
Okay, so we're going to, I think it's on the way. Voilà.
Okay, perfect. Thanks a lot. So, yes, basically the study design was followed pretty much the generic protocol of Epicenter. In a bit more detail, we did a retrospective cross-sectional mortality survey, and we included a seroprevalence survey, where we used cluster sampling. The study population was Greater Omdurman, all the people living there. Omdurman is the biggest out of the 3 cities which make up Khartoum, the capital of Sudan, and where MSF also has a project. The study period lasted a bit longer than a month, from the 1st of March until the 10th of April 2021. For the mortality survey, we used questionnaire with the head of household, and we used a recall period of a bit more than 2 years, from the 1st of January 2019 until March 2021. The sample size calculation was done based on the mortality of people of 50 years and above, and we aimed to include around 3,600 households. Then in a cluster, there were about 30 households, and each of the households participated in the mortality survey. Whereas a random 4 out of these also additionally then participated in the seroprevalence survey, where we used the antibody rapid test from biosensor. We estimated the sample size at around 3,200 people. Additionally, we collected dry blood spot for laboratory analysis. The data for the mortality for the seroprevalence survey was based on the data from around 2,400 people. We had an intra-household refusal rate of below 20%, and an additional 19% of people were absent even after 2 revisits, which were mainly done on the weekends. For the results, we got actually a pretty high seroprevalence of around 34.2% based on the rapid test. And after we did some adjustments according to the performance of the rapid test based on the literature, we even had an adjusted seroprevalence of around 35.4%. Here in this graph, you can see the seroprevalence by 4 different age groups, from the youngest until the oldest. And you can see already that there is an increase in seroprevalence from the youngest, everyone of 20 years and below, with a seroprevalence of 27.3%. Up to the significant highest seroprevalence was seen for the people of 50 years and above. There we reached a seroprevalence of around 50.2%, and after adjustments, even 55.1%. The main difference comparing the data from Sudan to the data, for example, from Europe, is that highest prevalence were found in the oldest age group, and not as in Europe, it's commonly seen in working class age groups, which have commonly most of their contacts. So the results for the mortality survey was based on around 27,000 people, including 319 deaths. Here on the upper graph, you can see the number of deaths by month and age group based on our survey data. Below that, you can see the official countrywide COVID-19 deaths for the whole of Sudan. You can already see that there is a coherence between our data and the countrywide COVID-19 data. Focusing a bit more on the death rate, comparing the pre and the pandemic period, there was, for the overall population, there was a significant increase for the pandemic period, which was around 67% increase. For the people of 50 years and above, we had a pre-pandemic death rate of around 0.57, and the pandemic death rate of around 0.99, which was again significant, and the increase was around 74%. Whereas for the remaining groups, we did not got a significant difference between the 2 periods. In conclusion, we estimated a seroprevalence based on the rapid test of around 34% for the whole population, which was even higher for the people of 50 years and above. Based on the Sudanese involved in our study, older people, they have much more time to socialize, and they spend a lot of time with the extended family. And this actually could explain our obtained infection pattern. The adjustments according to the ELISA results are still ongoing. Then we also estimated the overall population of Omduran, which we estimated at around 3 million people. And our estimates showed that already about 1 million people were infected with SARS-CoV-2. Then focusing a bit more on the mortality data, we saw, comparing the pre and the pandemic period, we saw an increase for the overall population, which was particularly strong for those people of 50 years and above. Now, looking a bit more in detail on this data, the excess mortality was, for the overall population, was 67%, which would mean that there is an excess of around 6,800 deaths. For the people of 50 years and above, the excess mortality was around 74%, which is an excess of 4,700 deaths. However, the main limitation of our study was the long recall period, which was a bit longer than 2 years. Here you can see the very first bit simple estimation of the infection fatality rate. And we had for the overall population, we had an infection fatality rate of 0.64%. And comparing this infection fatality rate to the estimates of Europe, it's actually pretty similar. Then for the people of 50 years and above, the infection fatality rate was 2.55%, which is again pretty similar to the estimates of Europe. Then there was an assumption among specialists that Africa eventually was not hit as hard by the COVID-19 pandemic, mainly because of the different age distribution with much less older people. For example, this was the case as well in Sudan. We had an average age of this 27,000 participants of 21 years, and only around 12% of them were above 50. However, what the assumption didn't take into consideration was a different infection pattern. So, as I told you before, in Europe, it's commonly seen that the highest infection are among working class age groups, whereas in Sudan, it was completely different, where we found highest prevalence in older people. So considering that the oldest age group was most affected by the COVID-19 pandemic, plus the estimate of the infection fatality rate is actually pretty similar to Europe, our results suggest that Omduran was hit very hard by the COVID-19 pandemic, and it caused a considerable amount of deaths. With that, I would like to thank everyone involved, from MSF, from the Ministry of Health, from the laboratory, and in particular to my direct supervisor, Manuel, and of course to all the study surveyors. Thank you very much.